Welcome to HCA 346, Module 2. In this lecture, we will review practice models and legal organization. Following today's lecture, students should be able to describe the wide range of medical practice models, characterize the relationships between physicians and healthcare institutions, understand the responsibilities of the practice manager, and appreciate the importance of the mission, vision, and values of a practice. The healthcare portion of the U.S. economy continues to increase due to population growth, the aging population, and other factors. This continued growth is one reason the U.S. healthcare system needs transformation and reform. Medical practices play an increasingly important role in this transformation as practices become integrated into the overall delivery system. As such, reform cannot occur without physician involvement. Integrated practices are those that are part of other organizations. Multi-specialty practices are growing, with the share of physicians in multi-specialty practices increasing to 25% from 22.1% in previous years. These shifts bring new challenges for practice managers related to competitive pressures and the complexity of managing a large medical practice. Before one can begin to address these challenges, one must understand the medical practice in the context of the overall healthcare system. Exhibit 2.1 in your textbook illustrates the pivotal role that the medical practice plays in the health system. A fundamental aspect of any organization, including medical practice, is its governing framework. This framework includes the board of directors or trustees and senior management. As illustrated in Exhibit 2.2 in your textbook, governance is guided by an organizational mission, vision, and value statement. The philosophical foundation provides a basis for strategic planning, which is a means of creating the goals and operational objectives of the medical practice. All aspects of decision making by the practice should be guided by the mission, vision, and values. The mission of the organization is the reason for organizational existence. The mission statement describes the overall organizational purpose and intent. The vision of the organization describes the future state desired by the organization if the mission statement is achieved. And the values of an organization indicate the beliefs that the organization holds most dear and how the organization behaves as an entity adhering to those values. Medical practices have many stakeholders, both internal and external to the organization. An effective medical practice is conscious of all of these relationships and carefully engages with them to carry out the organization's mission. The practice manager and all other practice leaders must understand the needs and concerns of all of these constituencies and are critical conduits who must translate the input of the governing body and the external stakeholders to the operational units of the practice. The functional structure of a medical practice is illustrated in the slides above. It demonstrates the relationship between operational aspects of the practice and the internal and external functions that support practice operations and engage with the external environment. Practices can be organized in a wide range of forms, from small individual or solo practice to a large, highly organized practice. The larger the practice organization, the more structured, complex, and integrated it will be. The degree to which a practice is integrated ranges from virtually no integration, as with solo practice, to moderate integration, such as group practice, which may include many providers and numerous specialties, to a fully integrated practice that is wholly owned by a subsidiary of a healthcare delivery system or an ACO. Integration of medical practices is discussed in terms of two dimensions. First is the issue of integrating business and administrative services such as billing and marketing. Second is the issue of clinical services integration. Two key characteristics of multi-specialty group practices include that they are highly integrated with a common governance and leadership or management structure. They have a highly developed corporate system for managing finances and ensuring compliance with regulatory agencies. They differ greatly in operation and governance from solo practices, which are largely overseen by the practitioner who runs the practice. Practices may choose to integrate for a number of reasons. The most prevalent is due to the economies of scale that is achieved by pooling resources to carry out the necessary functions that support the operations of the medical practice. One of the most important economies of scale for medical practices is the ability to manage the complex aspects of today's practice, including finances, the regulatory environment, and the increasing need for the practice to respond to the changing healthcare environment. Many important organizational elements must be considered when planning the form the medical practice will take. The factors include taxation, liability, the number of members, ownership, extent of personal flexibility, and autonomy allowed, transferability of ownership, capital formation, and vision. Practices that are solo provider practices or sole proprietorships place individual responsibility on the individual practitioner to manage the financial, service, and other aspects of the organization. This form of ownership offers the advantage of control, but holds the practitioner accountable for the entirety of their practice operations. Practices may also be formed as corporations. This status means that a corporation may enter into legally binding contracts, including debt obligations. In addition, because a corporation is seen by the law as an artificial person, it can be prosecuted for a variety of criminal behavior, such as fraud, wrongful death, and other criminal acts. It can be sued for negligence or liability, can be licensed, and must pay income tax. These features provide part of the appeal for a medical practice forming as an organization, as it may act as a single entity even though it may include many individual providers. The corporation structure protects the individuals that are part of the organization from corporate liabilities, with the exception of medical malpractice liability, which does remain the responsibility of the individual provider. Corporations may be either for profit or not for profit. There are key advantages and disadvantages to each profit structure. Keep in mind that not for profit does not mean the organization does not make a profit. Rather, it dictates how profits are utilized within the operation of an organization. Physicians may also be part of integrated health systems that are made up of hospitals and medical practices. These larger entities can be either for profit or not for profit. For profit entities may be private or even publicly traded, depending on the facility size. Medical practice groups that are part of an integrated health system enter either employment or affiliate contracts with the system. The employment of physicians or affiliation of physician practices with other healthcare entities takes different forms. Employment agreements typically are the most straightforward arrangement. In this arrangement, the physician becomes an employee of the organization, and often the working arrangement is detailed in the employment agreement. A controversial area of contracts for providers is the restrictive covenant. This provision sets certain parameters, usually related to future working restrictions if the provider leaves the practice. A restrictive covenant restricts the practitioner from engaging in the practice of medicine for a certain period of time in a defined location surrounding the previous practice. Some states prohibit restrictive covenants and other states discourage them. However, they are perfectly legal. In September of 2024, the FTC had proposed to ban restrictive covenants for many individuals, but not all. However, injunctions were filed to overturn the nationwide ban on the basis of abusive power by the FTC in issuing a ruling outside of their scope. As a result, restrictive covenants have not been overturned. However, several states do have restrictive covenant limitations for primary care providers due to known shortages. Contract terms are always stated in the contract. They include the length of the contract, under what state laws the contract is governed, whether arbitration will be used as a method for settling disputes, and any other conditions related to how the contract is administered. Effective contracts also have a termination process or a termination provision. These clauses specify how the parties of the contract will conduct themselves once the contract has expired and how the contract can be otherwise terminated. Tail coverage of malpractice insurance is another aspect of ending the practice relationship. This coverage extends insurance protection to the provider for all prior occurrences of alleged or actual malpractice that occurred while employed by the practice. These policies can be very expensive, therefore, the contract should specify who is responsible for purchasing tail coverage. In many cases, the practice requires the provider to purchase tail coverage. In order for contracts to be enforceable and considered legally binding, they must contain 5 elements: an intent to enter into an arrangement, an offer, acceptance of the offer, con- and consideration of economic benefits such as salary in exchange for services rendered, and a legal capacity to enter into the agreement. Benefits and compensation provisions specified in the employment contract include the salary the provider is to receive and how that salary is calculated, and we'll discuss more on that later. Many practices do use formulas to determine overall compensation. The contract also includes important non salary benefits, and those are provided on page 47 of your textbook as an example. This area of the contract also usually stipulates the practice furniture, equipment, and technology that the provider receives that is supplied by the organization versus what the provider has to supply. Ownership stake opportunities are provided by some private practices to allow providers to become a partner in the practice. These terms are typically detailed in the contract or included by reference in a separate agreement that specifies how the provider becomes an owner. Inclusion by reference is an important concept in contract law. Contracts that reference a document, such as a policy, essentially make that reference document part of the terms of the contract, and all parties to the contract must be clear on what terms from the document are incorporated into the contract to avoid future misunderstandings. In an affiliation agreement, the practice signs a contract with another party to provide certain specific services under a contractual agreement. A major difference between an affiliation agreement and an employment contract is that under affiliation, the provider remains an independent contractor and continues to manage his or her own practice. Any practice restrictions are enumerated in the affiliation agreement. Culture is defined as the beliefs, customs, practices, and behaviors of a particular group. Culture dictates how an organization conducts business, what it values, how it gets things done, and how it views itself. So, the culture of an organization defines how it treats its members and what behaviors it expects from them. Culture is a powerful force. As Peter Drucker said, culture eats strategy for breakfast. The relationships between practitioners and institutional providers, such as hospitals and healthcare systems, have often been strained because of the significant cultural differences between these parties. Medical practices have historically been less formal than hospital professional collegial organizations. In these organizations, the primary producer is also the owner who governs the organization. So often, the cultures of the two healthcare segments clash and create management problems that must be addressed by the medical practice. Part of the problem centers on the expectations of each party being established prior to the acquisition or affiliation. A cultural fit survey is essential to determining compatibility, as is having a clear understanding of what each party wishes to accomplish as a result of the combination of the organizations. Culture is both codified by formal policy and procedure, and imbued by informal means through the behavior of its members. The more the culture is aligned with positive behavior, the more effective an organization is. As healthcare has evolved, we have seen many innovative practice models that have been created over the past 10 to 15 years. Accountable care organizations were created by the Patient Protection and Affordable Care Act, and the ACO is defined more by what it does than by its structure. An ACO is a group of providers who share responsibility for a population of patients regarding the quality, cost, and coordination of their care. ACOs can be any combination of group practices, practice networks, hospitals, or hospital employed physicians and providers, or they can be joint ventures with the provision that they must be able to receive and distribute payments. All members of the ACO do not have to belong to a single entity. They can be bound by a contract. However, an ACO must include physicians in its membership. The ACO works with insurers, the largest being Medicare, to achieve improved health outcomes. Specifically, they seek to accomplish the following goals, often referred to as the triple aim: improve population health, improve patient experience, and reduce the total cost of care. Most of the arrangements between the payers and the ACO involve incentives for reducing costs, such that the ACO receives payments if agreed on targets are met. A central aspect of the ACO is to provide enhanced preventative care. Therefore, the care delivered by ACO primary care providers is central to the success of the ACO. The Patient Protection Affordable Care Act established an ACO for Medicare providers called the Medicare Shared Savings Program as part of the reforms to the Medicare system. The MSSP is intended to improve outcomes and increase the value of care by rewarding ACOs that lower their growth in healthcare costs while meeting performance standards on quality care and patient-first initiatives. ACO programs have now also expanded to commercial insurance markets such as Anthem and Humana. ACOs are primarily funded based on per member per month dollar amounts from commercial payers, which translates to a set amount of money per attributed member per provider per month for an annualized amount. If an ACO participates in the Medicare Shared Savings Program, they have to participate in the program for 1 year, and then they are paid 9 months after the conclusion of the previous year. And their payment is essentially based on the idea of balancing a checkbook. If your benchmark or your budget for your defined patient population is $10,000 and your expenditure per patient per month over the year of performance is $8,000, then the ACO gets to keep a portion of the difference between the $10,000 benchmark and the $8,000 expense. Depending on the track that the ACO is in, depends on the percentage of that $2,000 that an ACO gets to keep and distribute to its physician members. We'll discuss more about ACOs a little bit later in this semester and get more into the weeds on the innovative practice model. Patient-centered medical homes are a model concept that was introduced by E.H. Wagner in 1998. Unlike many of the approaches pervasive in the healthcare field today, such as more efficient treatment, better drugs, new care modalities to care for the sick, the PCMH model is focused on prevention and early intervention for patient care. This focus is especially appropriate for the chronically ill, as early intervention can delay a worsening condition and prevent the emergence of further complications and other consequences of the chronic illness. The PCMH helps ensure continuity of care and offers expert guidance in navigating the healthcare delivery system by serving as the starting point for all of a patient's medical concerns. Any physician practice can become a PCMH by adhering to the 6 principles outlined by the NCQA. The overall promise of the PCMH is that it helps frame a medical practice's approach to offering value-based care. One way it does so is by allowing the practice to seek simplification for complex environments. The payment system that drives practice management encourages incremental improvement in activities, bolting on the process after process, procedure upon procedure, making systems difficult to work with, rather than taking the time to think through the value that each process adds and how it operates. Integrated delivery systems can either be horizontally or vertically integrated healthcare organizations. Vertically integrated organizations increase their reach by adding similar service lines, such as hospitals, whereas horizontally integrated organizations increase in reach by adding related but different service lines. For example, a hospital organization might add physician practices. Integrated delivery systems are generally characterized as a large organization capable of providing a variety of services to their patients. Review the pros and cons of an integrated delivery system on page 59 of your textbook. Integrated delivery systems can also be the home of a clinically integrated network. In clinically integrated networks, there is a central data model, and then it is partnered with outside providers that are not part of the host organization to share data and to share goals among a similar service population. Again, we'll learn more about CINs later in the semester. Tremendous growth has been seen in recent years in the size and scope of medical practices. This growth is usually accomplished by either organic growth or through mergers and acquisitions. A merger is a transaction that creates a new single entity from combining 2 or more previously single organizations, whereas an acquisition occurs when one organization purchases the full assets of another entity. In the case of an acquisition, the acquiring organization usually remains intact. One danger that can occur from a merger or acquisition is illustrated in Exhibit 2.8 of your textbook. The creation of too many silos for patients to navigate is very dangerous. Healthcare professionals often see their work as a series of discrete activities. each under separate control. The patient or the patient's family then have different views on healthcare activities. They see their encounter with the practice as a single event and a part of an overall experience. When mergers or acquisitions take place, the practices involved must be sure to fully integrate all parts of the new practice to avoid silos being created in the care encounter. Exhibit 2.9 in your textbook is a great visual to detail the steps involved to ensure a successful merger and acquisition. The COVID-19 pandemic had a significant impact on the practice of medicine and healthcare delivery in general. Although the pandemic is not the only factor driving change in the practice of medicine, its effect has been unprecedented in accelerating the changes in medical practice models. These changes include the decline of independent physician owned practices, the increasing adoption of telemedicine, and the emergence of new models of medical practice and practice ownership. Many independent medical practices have struggled to remain viable. Some have been forced to merge with larger organizations, while others have closed their doors altogether. While independent practices do still exist, they are becoming increasingly rare in the current healthcare landscape. The pandemic accelerated the decline of these physician owned practices, and there are several reasons for this decline, which include increased regulatory burden, financial pressures, staff burnout, technical costs, changing demographics, preferences of new physicians, hospital consolidations, and service line diversifications. The increased regulatory burden that independent practices must comply with has been steadily growing. Compliance is time consuming and costly, particularly for smaller practices. Larger practices have the ability of having dedicated compliance staff to assist with the regulatory burden. Solo practices typically have their compliance outsourced or run by the physician that is running the practice. Independent practices often also face financial constraints as a result of declining reimbursement rates from insurers, increased competition from larger healthcare organizations, and rising costs for supplies, equipment, and staff. Supply chain disruptions, supply shortages, and inflationary pressures have also increased cost. Staff burnout was difficult prior to the pandemic. However, the pandemic exacerbated the longstanding issue of burnout among medical personnel. The prevalence of burnout among U.S. physicians jumped to 62.8% in 2021, compared to 38.2% in 2020. 1 in 5 physicians have said that they intend to leave their current practice within 2 years. In addition to burnout, healthcare technology is becoming increasingly complex and expensive with electronic medical records and other systems requiring significant investments in hardware, software, and personnel. It is important to note that practices that are continuing to utilize paper instead of electronic medical records, while they are few, do still exist. In those cases, practices on paper are no longer allowed to participate in value based care arrangements with Medicare due to the requirements for electronic data submission and usage and collection. This in turn impacts their ability to report MIPS, which impacts their revenue cycle and their reimbursement. We'll discuss more about the impact of MIPS and value based care reimbursement on the overall revenue cycle later in the semester. As the population ages and healthcare needs become more complex, there is also a growing demand for specialized care that may be difficult for independent practices to provide. And as a result, that care is then outsourced to a larger group practice. And as the population ages and healthcare needs become more complex, there also is a growing need for specialized care from a physician standpoint. Therefore, new physicians tend to go into specialties and not as much into independent primary care practice. The days of a true cradle to grave family medicine provider or a full time hospitalist, in addition to having their independent practice, are slowly dwindling. Rarely do you see new physicians coming out of school being prepared to round at the hospital before and after clinic and see a full clinic of patients. Many hospitals have acquired physician practices in recent years, either through acquisition or joint ventures, and this trend has led to fewer independent practices and increased consolidation in the healthcare system. One of the things that independent practices have been doing to try to combat these areas of decline has been service diversification. Many independent practices have added non face to face services to their menu to allow for closer patient monitoring between office visits and for continual revenue month to month. Examples of these services include remote patient monitoring and care management programs such as chronic care management, primary care management, and advanced primary care management. These programs also allow providers more proactive management to prevent unnecessary costs and enhance value based care program success. While these are beneficial to the revenue cycle, they typically have large startup costs, sometimes require dedicated staff or outsourcing, which means paying a fee for those. And in the case of remote patient monitoring, requires access to technology that can send back data from the patient's home. So the startup costs of these are rather large, but over time, once they are used to scale, they do tend to pay for themselves. However, for many independent practices, reaching that scale of 200 or more patients, for example, is often difficult to do as there is cost sharing involved for the patient with these services. There's current legislation being proposed that would remove the cost sharing from such care management programs, which would be a huge win for independent practices. However, until that happens, while this is a great service for our patients, it does contribute to the decline due to large upfront costs and the cost sharing component. Care management programs are just one example of the use of telemedicine in practice. But with the need to isolate and prevent the spread of COVID-19, it did hasten the adoption of all forms of video and online services for things such as virtual visits and remote monitoring. Virtual services not only help protect the health of providers and patients from the spread of infection during the pandemic, but it also introduced a convenient and satisfactory mode of service, particularly for initial evaluations. Physicians have also used these services to provide in hospital consults to avoid the need for face to face contact. The pandemic created financial strain on smaller practices that did not wish to invest in new technology or were unable to do so. This places even more pressure on practices to consolidate. In recent years, new models of medical practice and practice ownership have emerged. Four investor types are now involved in medical practices: private equity, which establish relationships with medical practices to have potential for growth. These investors typically provide capital for expansion infrastructure and investment and management expertise. Because of corporate practice statuses, investors usually hold a minority stake in the practice for a negotiated return on their investment. Clinical operations are typically left to the discretion of the physicians, but this approach to practice raises concerns that there may be too much non clinical control over the practice of medicine and too much emphasis on profitability. Venture capitalist entities are often interested in innovation and seek out practices with the ability to develop new models of care delivery, such as telehealth and technologically enabled practice models. Their focus is on providing more flexible patient access and physician working environments. Health plans have also begun to enter the practice model arrangement. To achieve better care and management and utilization of resources, health plans have been shifting to vertically integrated systems that include providers. This may also be a way to expand care locations. And large employers may contract directly with providers to offer more efficient access to care for their employers. They're particularly interested in digital enhanced virtual care. We often see this in manufacturing where they partner with practices for occupational medicine support and triage support. Additional examples of emerging medical practice models include non traditional ownership models that offer primary care services, such as the Amazon Clinic, like One Medical, Humana's Centerwell Senior Clinic, the clinic at Walgreens, which is a collaboration between Walgreens and Signify, and the CVS Minute Clinics. These new forms of practice compete directly with traditional primary care practices, promising lower cost, easier access, and greater convenience. They provide a more consumer oriented retail model of healthcare in which prices are provided up front and a limited selection of common services are provided with an emphasis on convenience. In March of 2023, Atrium Health in Charlotte, North Carolina, announced a partnership with Best Buy to provide certain hospital services to patients in their homes. This partnership is designed to enhance the patient experience, tapping into specially trained Geek Squad agents to provide and set up in home wearable technology that allows a patient's vital signs to be monitored remotely by an Atrium Healthcare team around the clock. Between 2020 and 2021, the number of physicians employed by hospitals and corporate entities increased by 48,400. The second half of 2020 alone saw a 3.4% increase in the growth rate of hospital and corporate employed physicians. This accelerated growth rate appears to have been driven by the pandemic. By the beginning of 2021, 69.3% of physicians were employed by corporations or hospitals. The Midwest had the highest share at 76.9%. For profit ownership of medical practices, as opposed to not for profit ownership, is not inherently good or bad. Both for profit and not for profit organizations may engage in predatory behavior. However, it is critical that ethical frameworks are built into all of these arrangements to reduce conflict between investors and providers to ensure the proper care of patients. As you complete Module 2, additional articles 7 through 10 and additional videos 5 through 6 have been posted on Blackboard for your review. These provide additional insight to the concepts that have been discussed in today's lecture. Once you have reviewed the lecture and read and watched these additional articles and videos, students should then complete the Module 2 discussion board. Should you have any further or more specific questions about the content presented in Module 2, please do not hesitate to email your professor.